Right, okay. I think, Sujit, I think you have to, give me a second. I think, can you share your screen again? I think, is that okay? And Rohit, I'll make you a co-host, yeah? Okay. Right, okay, so, I have to get rid of this.
The slides are moving, sir?
I don't know. Yeah, I think you don't have, whose slides are there? Who's presenting the slides? Is it Sujit, yeah?
I'm presenting the slide directly.
Okay, that's fine. Okay. Right, okay, so I'd like to start by introducing Sujit Kumar Kar. He's a co-editor of the Journal of Global Psychiatry Archives. He's publishing very actively and exciting studies. And today, I think he's professor at the university in India. Which place?
Lucknow.
Lucknow, right. Right, okay. And where is Lucknow then? I don't know.
Lucknow is in the north part of India, around 500 kilometers from national capital, Delhi.
All right, okay, sorry for, anyway, and this is about TMS, neuromodulation strategy in the management of bipolar affective disorder. And yeah, please start. Thanks for coming and just starting.
Good afternoon, everybody. Thank you, Professor Renner and the team for giving me opportunity to present in this international forum. I'll be talking about scope of neuromodulation strategies in the management of bipolar affective disorder. My presentation will follow this outline. First, I will be talking about the overview of management of bipolar affective disorder. Then I will be talking about overview of various somatic treatment and neuromodulation treatment that are quite relevant for bipolar affective disorder management. Then I will be talking about evidences and comparisons and the scope of neuromodulation in the management of bipolar affective disorder. So coming to the overview of management of bipolar affective disorder. So when we talk about management of bipolar affective disorder or any type of psychiatric illness, may it be any form of medical illness, when you talk about management of a illness, the main goals of treatment usually remains achieving early remission, early resumption of work, getting functioning so that the individual will get the better functioning as early as possible, to resume the better quality of life, and to minimize the disability. These are the goals of management, may it be for psychiatric illness, may it be for bipolar affective disorder, may it be for any medical condition. When we talk about management bipolar affective disorder, the goals are usually to control the symptoms as early as possible, to preventing the relapse of further episode, to prevent suicide, to limit the disability, to optimize the functioning of the individual, and of course to deal with stigma, because stigma is associated with almost all the psychiatric illnesses, including bipolar affective disorder, and stigma is attributing to a lot of dysfunction in the individual level and the family level. So dealing with stigma is an important goal in bipolar affective disorder management. When we talk about pharmacological management of bipolar affective disorder, usually in a standard clinical practice, clinicians they initiate the treatment after making the diagnosis. Depending upon the response, a subsequent step usually goes to optimization of the dose of the medication. Even after optimization, if the individual is not responding adequately, then the subsequent strategy usually becomes switching to another medication, which will be beneficial for the patient. Even after switching, if the strategy is not working adequately and patient is not responding well, then usually clinicians consider augmentation strategies. Then failure of augmentation, subsequently the clinicians, they usually combine multiple medications together, multiple strategies together, that we usually call as multimodal management approach. So this is how the treatment ladder for bipolar affective disorder is also used. We talk about the various management options for bipolar affective disorder. Broadly, there are three things that we use for management of bipolar affective disorder. One is the pharmacotherapy, that is very commonly used, very widely practiced, stands basically on mood stabilizers, antipsychotic medications, and some augmenting pharmacotherapy. Second strategy can be psychotherapy, and the third strategy can be somatic treatment. And clinicians often consider pharmacotherapy in combination with psychotherapy or somatic treatment if the symptoms are quite serious enough or severe enough. So the latest guideline usually talk about pharmacotherapies, like in the management of bipolar affective disorder, people talk about what is the most suitable medication for acute phase of management, what is the suitable medication for maintenance phase treatment, which medications are more suitable for treating the manic episode, which medications are more suitable for treating the depressive episode. There are some broad spectrum medications that are effective in both acute phase as well as maintenance phase, in manic phase as well as in depressive phase. One of these medication is lithium, quetiapine, olanzapine. These medications are effective in both acute phase as well as in maintenance phase, both depressive phase as well as in the manic phase. So a lot of evidences exist regarding which medication is more effective, which medication is less effective, which medication is more tolerable, which medication is less tolerable with respect to the management of bipolar affective disorder. Other than that, in the recent decade, a lot of research is going on to target some newer receptors, like people targeted opioid receptors, various other serotonergic receptors, glutamatergic receptors, cholinergic, histaminergic receptors. So various molecules are developed in the, and various molecules are in the process of development in different stages of trial, targeting different spectrum of receptors. Even people are targeting endothelial reticulum mitochondrial activity, targeting those activities in the management of bipolar affective disorder. Even people are targeting the nitrous oxide, oxidative free radical scavengers are the molecules that are used in the management of various psychiatric disorders, including bipolar disorder. We all know that when there is recurrent of mood episodes, that leads to significant changes in the cognition, significant functional impairment, that also result in impairment of the resilience of the individuals. All these changes, clinical changes, concurrently happen with the biological changes in the brain. There are some inflammatory changes. Various inflammatory markers are raised when there are recurrent mood episodes. Oxidative biomarkers are raised in the brain when there is recurrent mood episodes. Mitochondrial and endothelial reticulum dysfunction happens. Channelopathies also happen. Cellular resilience gets altered. All these changes increases the vulnerability to stress and increases the risk of having another mood episode. So the vicious cycle goes on. Increasing vulnerability increases the risk of a mood episode. Again, all these clinical biological changes happen that further deteriorates the individual's resilience, individual vulnerability. So this is how the neuroprogression happens in bipolar affective disorder. Researchers, they identified there are some voluntary processes and there are some automatic processes that happen in patients with normal individuals, and these automatic and voluntary processes gets altered in patients with bipolar affective disorder. Particularly for the voluntary processes, the dorsolateral prefrontal cortex, ventrolateral prefrontal cortex are responsible, For automatic processes, dorsomedial prefrontal cortex, ventromedial prefrontal cortex, orbitofrontal cortex, anterocingulate cortex, these areas are basically responsible. So when an individual develops a depressive episode or a manic episode during the course of bipolar affective disorder, the voluntary process and automatic process, these areas are either hyperactive or inactive. Probably these areas, that's why these areas are potential targets of neuromodulation in the subsequent treatment plan. Now we can talk about the various neuromodulation techniques. If you talk about neuromodulation technique, the most ancient one is electroconvulsive therapy that was introduced in 1939, late 1930s, for clinical purpose. Nearly took 40 years to get the US FDA approval for in the treatment of psychiatric disorders. In late 60s, transcranial direct current stimulation was introduced for the management of various psychiatric disorders. In late 90s, transcranial magnetic stimulation was introduced. The magnetic stimulus is used for modulating the neuronal activity. Subsequently, deep brain stimulation, an invasive technique, was introduced. Epicranial stimulation and magnetic scissor therapy were introduced subsequently. This is how the neuromodulation techniques are evolved over past several decades. So this graph basically shows the FDA approval status of various neuromodulation techniques for different psychiatric conditions, neuropsychiatric conditions. Late 1970s, electroconvulsive therapy was approved by FDA. Late 90s, vagus nerve stimulation was introduced for management of epilepsy. Deep brain stimulation was approved for management of essential tremor. In 2000 and subsequently, deep brain stimulation, RTMS, vagus nerve stimulation, they are used for clinical conditions like OCD management, depression management, and subsequently over past 2 decades, the various innovative techniques like deep transcranial magnetic stimulation, deep brain stimulation, magnetic scissor therapy, all these techniques were experimented in a lot of neuropsychiatric conditions, and they got approval for management of those conditions. So basically, when we talk about neuromodulation technique, it ranges from electroconvulsive therapy to magnetic stimulation techniques to transcranial direct current stimulation technique to vagus nerve deep brain stimulation technique, magnetic scissor therapy. Other than this neuromodulation technique, a lot of research is also happening with respect to use of ultrasound stimulation, thermal stimulation, photic stimulation of specific brain areas for the treatment of various neuropsychiatric conditions. We all know that these neuromodulation techniques, they have a spectrum of mechanisms by which they they benefit the individual. So if we talk about electroconvulsive therapy, several mechanisms has been explained, ranging from neurotransmitter correction to altering the blood-brain barrier permeability, to change the metabolic activity of various brain areas, to enhance the production of BDNF, to suppress the cortisol, hypothalamo-pituitary adrenal axis suppression, neuroplastic effect. These are various mechanisms explained for the therapeutic effect of electroconvulsive therapy. When we talk about transcranial magnetic stimulation, it mainly causes focal cortical neuromodulation. If you apply high frequency magnetic stimulus, then it causes neurostimulation. If you apply low frequency stimulus, it causes local inhibition. Similarly, if you talk about transcranial direct current stimulation, it causes again focal neuromodulation. Cathode placement causes cortical inhibition. Anode placement causes cortical stimulation. Vagus nerve stimulation, basically it causes modulation of various brain areas that are related to the vagus nerve nucleus, mostly locus coeruleus and brainstem areas responsible for mood regulation. They are modulated through vagus nerve stimulation. Deep brain stimulation is basically recommended for the treatment of OCD treatment and Parkinson's disease, essential tremors. Other than this, it has been tried in various patients with bipolar affective disorder. It modulates the deep brain areas, the neuronal firing of the deep brain areas. Magnetic scissor therapy is having a very similar mechanism, which is quite close to the mechanism of electroconvulsive therapy. Let's talk about neuromodulation and management of bipolar affective disorders one by one. If we talk about electroconvulsive therapy in the management of bipolar affective disorder, as per the CANMAT guideline, electroconvulsive therapy augmentation is considered as a second-line management option for the management of type 2 bipolar depression. So usually the first-line management remains mostly related to pharmacotherapy, either lithium, olanzapine, fluoxetine combination, or quetiapine. They are the monotherapies, or they can be used for the as a first-line treatment. Electroconvulsive therapy is considered as a second-line treatment, as a augmentation to the ongoing pharmacotherapy. So mood stabilizers are the mainstay of treatment of bipolar affective disorder. Most medications that stabilize the depressive episode, they have a risk of causing switch to mania. And those who are controlling the manic episode, they may induce some depressive symptoms. So electroconvulsive therapy is an effective treatment modality which has having anti-manic property as well as antidepressive property. So it controls the manic episode, it controls the depressive episode as well. The limitation with electroconvulsive therapy is the effect is short lasting. You cannot give electroconvulsive therapy for quite long time. Though people have tried electroconvulsive therapy as a maintenance therapy once in every 2 weekly, once in a month, for longer time to prevent the further relapse of the mood episodes. So mostly the effect of electroconvulsive therapy is acute and short lasting. If you want a long lasting effect, probably you need to consider maintenance electroconvulsive therapy as an alternative option to prevent the relapse of mood episodes. The studies related to short-term outcome with respect to ECT in patients with severe drug-resistant mixed affective episodes in patients with bipolar affective disorder. They estimated what is the response to electroconvulsive therapy sessions and what is the remission rate. Response rate is somewhere around close to 42%, whereas remission rate is somewhere around 30%. Patients, they achieve remission after electroconvulsive therapy. So these are the patients who received an adequate trial of pharmacotherapy, psychotherapy, mood stabilizers, antipsychotics. But despite of all those treatments, the mood episode is refractory to treatment, and add-on electroconvulsive therapy is able to achieve remission nearly 1/3 of those patients. The researchers, they identified some risk factors. Who are those individuals who are non-responsive to electroconvulsive therapy? It is very important to know, because when you decide for electroconvulsive therapy, the expectation of the patient is very high that if I am going for electroconvulsive therapy, then it is quite obvious that I will be getting some more response. But if the patient is having comorbid OCD, if the baseline score of mania on Young's Mania Rating Scale, YMRS, is very high, if the length of the current episode is too long, then probably these individuals, despite of ECT augmentation, they may not have adequate response to this augmentation strategy. So it need to be explained to the patient's family members, and it should be, the clinician need to be aware of this. So in treatment-resistant bipolar depression, people have tried conducting various RCTs where they considered electroconvulsive therapy as monotherapy versus algorithm-based pharmacological treatment. We have discussed about the standard treatment algorithm. People start with either first-line treatments, like if you are treating a depressive episode, bipolar depressive episode, the first-line treatment usually in most of the countries, they either prefer monotherapy of quetiapine or fixed dose of olanzapine fluoxetine. Many people, researchers, clinicians, they try with lithium. As a second line of treatment, people may consider lamotrigine or other mood stabilizers. So this is how you start the treatment, you optimize the treatment. Depending upon the response, you switch to another treatment strategy. This is how the pharmacological algorithm progresses. So in this study, they compared the pharmacotherapy versus unilateral brief pulse electroconvulsive therapy. And the effect was monitored till 6 weeks as an acute response. In this study, they found that the remission rate in both of the treatment groups are not significantly different. Those who are receiving pharmacotherapy and those who are receiving electroconvulsive therapy alone, they have a similar kind of remission rate. But the response rate of electroconvulsive therapy group is significantly more than 2 times higher than that of pharmacotherapy group alone. So individuals who are receiving electroconvulsive therapy, they are more likely to respond acutely than those who are receiving pharmacotherapy alone. Response rate to electroconvulsive therapy has been compared with unipolar depression versus bipolar depression. The response rate is quite similar. Individuals with unipolar depression, individuals with bipolar depression, they have almost similar rate of response. But those individuals who are having a bipolar depression, they show the response bit earlier. So unipolar depression probably require more number of sessions of electroconvulsive therapy to get a response, whereas bipolar depression patients, they respond within a relatively less number of sessions of electroconvulsive therapy. Meta-analysis that included 6 studies where the unipolar depression patients are 790, whereas bipolar depression patients are 316. This study found that the response rate to unipolar depression is around 51%, whereas response rate to bipolar depression is somewhere 53%, which is very close. It indicates that electroconvulsive therapy is a useful treatment strategy for management of both unipolar depression as well as for bipolar depression with equal effectiveness. Researchers attempted to use electroconvulsive therapy in an elderly population with more than 65 years of age with bipolar depression. It was found that there is significant reduction of the depressive symptoms, and at the same time, because elderly population, they are very much concerned about the cognitive functioning. The cognitive reserve of the elderly population is relatively less in comparison to the adult population because of the aging process and ongoing bipolar affective disorder that is also affecting the cognitive process. They found that there is improvement in the depressive symptoms and there is at the same time improvement of the cognitive function. Electroconvulsive therapy is known to have cognitive side effects. Despite of that, this study found that there is improvement in the cognitive functioning. And most of the patients, they tolerated the therapy well with no noticeable side effects. So electroconvulsive therapy can be considered as a safer option for the treatment of severe mood episodes and mood episodes in the elderly population. Electroconvulsive therapy was also tried in special population like pregnant females and particularly those who are having severe episodes of mania and bipolar depression. Pregnant females with bipolar depression and severe episodes of mania, they responded well to electroconvulsive therapy and they tolerated well to electroconvulsive therapy. So there is no pregnancy related complications in most of the patients. But what is important in dealing with the pregnant females with bipolar depression or bipolar manic episodes, we are planning for electroconvulsive therapy for the utmost safety of the patient. There is a need of interdisciplinary coordination, particularly with obstetricians and pediatricians to take care of if there is any complication arises during the course of treatment. We can take support from those other department colleagues. So now talking about transcranial magnetic stimulation in bipolar affective disorder management. Researchers, they estimated the cortical excitability in patients with mood disorder. To estimate the transcranial magnetic stimulation is one of the technique by which you can estimate the cortical excitability. You estimate the resting motor threshold, and that is an indicator of what is the excitability of the cortical neurons. So interhemispheric asymmetry in the cortical excitability is seen in patients with bipolar affective disorder. Variation in cortical excitability in patients with is observed in patients who are having symptomatic affective episodes like manic episode, those who recently remitted from the affective episode, and in the healthy subjects as well. The motor threshold in remitted first episode manic patients, it reflects that if you treat these mood episodes with pharmacotherapy or neuromodulation, the motor threshold becomes lower. So it corresponds with the therapeutic response. So if you alter the cortical excitability through neuromodulation, probably you can bring a therapeutic response. In a retrospective analysis, patients with bipolar depression, both type 1 bipolar and type 2 bipolar, they are included. They attempted with high frequency RTMS. High frequency RTMS is known to produce stimulation of the underlying neurons. So they have given this high frequency RTMS at 120% of the resting motor threshold over the left dorsolateral prefrontal cortex. 3,000 pulses were delivered for 30 sessions. This is the FDA approved protocol for the management of depressive episode by using RTMS. So this protocol was used. Patients who are enrolled for in this study, they already received pharmacotherapy for depression, either in the form of one or more mood stabilizers without any antidepressants. So they have received these multiple failed attempts of pharmacotherapy before enrollment to the RTMS trial. At the end of 25 sessions of RTMS, these sessions are delivered on daily basis, 1 sessions per day. So 5 sessions in a week. At the end of 5 weeks, 25 sessions are delivered, and the response rate is somewhere around 41%. But at the end of 6 weeks, when 30 sessions are delivered, the response rate is almost double. So more number of response, more rate of response is elicited if you give more number of sessions of RTMS. So probably individuals with treatment refractory bipolar affective disorder, they require more number of sessions to have a better response. RCTs, they evaluated the safety and efficacy of deep RTMS. Deep RTMS is a specialized form of RTMS where the penetrability of the magnetic stimulus becomes more. In a conventional RTMS, when you use it, the penetrability is somewhere around 3 centimeters. When you use deep RTMS, deep TMS, the penetrability goes up to 5 centimeters. So conventional RTMS is only effective for modulating the cortical activity of superficial cortical neurons, whereas deep TMS may be able to alter the cortical activity of superficial cortical neurons as well as deep cortical neurons. And the volume of stimulation, neurons, volume of brain area that is stimulated by DTMS is much higher than the volume of brain area that is modulated by conventional RTMS. So researchers, they use deep TMS in the treatment of resistant cases of bipolar affective disorder. Those individuals who are receiving active TMS, there is significant reduction of the depressive symptoms than those who are receiving the SAM treatment. And they estimated the response. They followed the patients for another 4 weeks to see whether the response is sustained over a period of time. But unfortunately, whatever improvement achieved during the initial part of the treatment, it is not sustained. It indicates that the therapeutic benefits that you get from RTMS are again acute. And if you want a sustained benefit, probably you require maintenance RTMS for the management. In this study, they found that the response rate of individuals who receive active RTMS, it is around 48%, whereas those who receive SAM TMS, it is half of that, that is around 24%. Recent systematic review and meta-analysis that included 56 randomized controlled trials with patients more than 3,000 adults with unipolar and bipolar depression. It evaluated the efficacy and acceptability of various non-invasive brain stimulation technique, including TMS, transcranial direct current stimulation, and theta wave stimulation. It is found that high frequency RTMS over left dorsolateral prefrontal cortex is having the highest level of evidence in terms of efficacy when you are treating the depressive episode, may it be unipolar depression or bipolar depression. So high frequency RTMS is having the highest level of efficacy. Those who are receiving intermittent theta stimulation, there is some improvement in reducing the treatment duration. The pharmacotherapy required, the drug requirement becomes less, the treatment duration becomes less, but the improvement is not substantial like the high frequency RTMS. If you are using continuous theta stimulation or bilateral TBS, these strategies are not much effective in the treatment of unipolar and bipolar depression. When we talk about the manic episode management, most of the studies that use RTMS for treating the manic episodes, they usually target the right dorsolateral prefrontal cortex. Those who are treating the depressive episode, they basically target the left dorsolateral prefrontal cortex. So left dorsolateral prefrontal cortex stimulation is required for the treatment of depressive episode. Right dorsolateral prefrontal cortex stimulation is required for the treatment of manic episode. So patients receiving high frequency RTMS over the right dorsolateral prefrontal cortex, they show significant reduction in the manic symptoms at the end of therapy. So for the treatment of the manic episode, safety and efficacy of accelerated RTMS protocol has been tried. So accelerated RTMS protocol is a modification in the conventional protocol. Conventional protocol of RTMS usually says that you give one session of RTMS on daily basis. You call it accelerated RTMS protocol when you give more than one sessions of RTMS per day. So in this scenario, they have given 30 sessions of RTMS over a period of 15 days. It means that 2 sessions of RTMS given in a given day. So high frequency RTMS over left dorsolateral prefrontal cortex is given 30 sessions over 15 days. Patients who are more than 60 years of age, they had significant higher rate of remission and response than those who are less than 60 years of age. If you refer to the research published a decade back, most of the research, they say that geriatric population are usually the poor responder to RTMS. The reason being, as the age increases, the cortex becomes atrophied. The atrophy of the cortex causes increase in distance between the cortical surface to the skull surface. So the penetrability is of only 3 centimeters and cortex is sinking. So the stimulus that is given by the RTMS coil is not reaching the cortical surface. Probably that is why the elderly individuals are not responding. This is the explanation given by the studies, most of the studies published a decade back. But the recent evidences support that even after cortical atrophy, elderly individuals, if you give high frequency RTMS, they can have a higher rate of remission response rate even than the individuals who are receiving, adult individuals who are receiving the RTMS for the treatment of depression. So older population can show significant improvement to anxiety and depressive symptoms when you give RTMS stimulatory protocol, high frequency RTMS over the left dorsolateral prefrontal cortex. Comparison between whether the individuals with type 1 bipolar, they respond well to RTMS, or those who are with type 2 bipolar, they respond well to RTMS. Some early evidences report that patients with type 1 bipolar disorder are having a better response to RTMS than those individuals with type 2 bipolar. The response rate, remission rate in type 1 bipolar rate is higher than type 2 bipolar. But it is also reported that type 1 bipolar patients, they also report more adverse effect to RTMS than type 2 bipolar disorders. So therapeutic effect and adverse effect go concurrently. Response in unipolar depression was also compared with bipolar depression. Response rate to RTMS in bipolar depression is significantly lower. It is found in a study published in 2021. Individuals with bipolar depression, they have a lower response rate than unipolar depression. However, similar kind of study was conducted in the subsequent year. That is also having a contradicting finding. Patients with bipolar depression, they have a better remission rate and response rate than patients who are having a unipolar depression. In unipolar depression, the response rate is somewhere around 40%, whereas in bipolar depression, the response rate is the double, somewhere around 80%. In unipolar depression, the remission rate is somewhere around 15%, whereas in bipolar depression, the remission rate is 3 times higher, around 45% have a remission rate. So we are getting some contradicting finding whether unipolar depression patients are responding better to RTMS or bipolar depression patients are responding better to RTMS. So both the studies are recent studies, but there is a difference in the sample size. The first study is having a very smaller sample size, whereas the second study is having a relatively larger sample size. So we need to have further studies in a very larger sample size with follow-up for a longer time to establish the fact whether unipolar depression is responding well to RTMS or bipolar depression is responding well to RTMS. Let's talk about transcranial direct current stimulation in bipolar disorder management. Randomized control studies exist with response to use of TDCS in the management of bipolar disorder. So it is TDCS is basically used along with the pharmacotherapy. Most of the patients were receiving mood stabilizer in one mood stabilizer. So TDCS is given in one group who is receiving mood stabilizer. The other group is giving medications alone. TDCS was not given. So they have two arms. One group is having pharmacotherapy plus TDCS. Second group is having pharmacotherapy alone. So it was found that combination of TDCS with pharmacotherapy, these patients are responding well to this treatment strategy. They have a higher reduction of the depressive symptoms in comparison to those who are receiving medication alone. They did a follow-up for 3 months and they found that again the benefits are not sustained. May it be electroconvulsive therapy, may it be TMS, may it be TDCS. The benefit that we are getting, they are mostly acute benefits. The benefits are not sustained over a period of time. This indicates that probably individuals who are receiving these neuromodulation techniques, they require some maintenance sessions in order to have a sustainable benefit. This study also concluded that those who are receiving TDCS with medication, they have less cognitive deficits than those who are receiving medications alone. Again, this study is limited because of has several limitations because of the small sample size, shorter intervention. Only 10 sessions were given in 5 days period. So usually, if you think of pharmacotherapy, it takes around 2 to 3 weeks time for the onset of action. And you have given in this study, researchers, they have given TDCS intervention for 5 days only. 2 sessions in a day over a period of 5 days. So probably this intervention period is shorter. So subsequent research may try with a longer sessions of more number of sessions and longer duration of TDCS to see whether the benefit is more or not. A trial that is better trial, bipolar depression electrical treatment trial. This is an ongoing trial. A lot of publications are coming from this better trial. Those individuals who are receiving active TDCS, they have placement of anode over the left dorsolateral prefrontal cortex and placement of cathode over the right dorsolateral prefrontal cortex. So TDCS is bit more beneficial, I will say, more superior than TMS, I will say, because in RTMS you will use RTMS placement of coil is only targeting one brain area. When you are using TDCS, you have option to manipulate 2 cortical areas simultaneously. There is a placement of cathode, there is a anode placement. Anode placement causes stimulation, cathode placement causes underlying cortical inhibition. So in this case, simultaneously left dorsolateral prefrontal cortex was stimulated and cathode placed over right dorsolateral prefrontal cortex, which inhibited the right dorsolateral prefrontal cortex. And one session is given per day and 10 sessions were given over a period of 2 weeks. And subsequently, over next 4 weeks, same protocol was given every 2 weekly. So a total of 12 sessions were given, 10 sessions on daily basis, then 2 sessions over next 4 weeks, every 2 weekly. A total of 12 sessions were given. So 10 sessions are acute treatment and 2 sessions are maintenance treatment. So there is a significant improvement in the depressive symptoms in the group who is receiving active TDCS in comparison to those group who are receiving SAM TDCS. This trial, the team, they have published another paper in 2021. They estimated also the possible association of inflammatory biomarkers and response to TDCS and bipolar depression. Individuals who are receiving TDCS treatment, active TDCS treatment, there is a significant fall of interleukin 6 levels. So they found that if an individual with baseline increased interleukin 6, it is a predictor of response to TDCS. Those individuals have a higher level of baseline increase in interleukin 6, they respond well to TDCS. The side effects associated with TDCS are very minimal and well tolerable. Risk of switch to mania is quite rare. The common side effects associated with TDCS are tingling sensation or numbness in the area where the electrode is applied or headache. These are the common side effects associated. Open label study, recent open label study that used TDCS in patients both with unipolar depression and bipolar depression. And these patients, they have received one failed medication trial before getting enrolled to the TDCS. 10 sessions were delivered over a 5 days time. Anode is placed over left dorsolateral prefrontal cortex and cathode is placed over right dorsolateral prefrontal cortex. At the end of the therapy, the patient group who received active TDCS, they have significant improvement of cognitive symptoms, depressive symptoms, as well as anxiety symptoms. Another study that pulled the data from 3 different studies evaluated the efficacy of TDCS in major depression, that is both unipolar depression and bipolar depression. The improvement of the depressive symptoms in unipolar bipolar depression are quite comparable. We found similar kind of findings in PMS studies. Unipolar depression and bipolar depression, they respond early, but the response rate is quite comparable. Patient with cognitive deficit, psychomotor retardation, anxiety, prominent somatic symptoms are probably respond better to TDCS. We can say that these are the clinical predictors of response to TDCS. So a clinician who is planning for TDCS augmentation for bipolar depression or unipolar depression, so these are the potential candidates. Those who are having cognitive deficits, prominent cognitive deficits, psychomotor retardation, anxiety, and prominent somatic symptoms along with the depressive symptoms, they are more likely to respond to TDCS treatment as an augmentation strategy. Possible role of TDCS in some newer areas, new target areas like left ventrolateral prefrontal cortex has been tried. Patients with bipolar disorder, left ventrolateral prefrontal cortex shows unusual higher activity during the reward anticipation. So when you are giving a reward or the individual is anticipating a reward, there is a hyperactivity of left ventrolateral prefrontal cortex. And this left ventrolateral prefrontal cortical activity is significantly unusually higher in patients with bipolar affective disorder. So if you modulate the cortical activity, you reduce the higher cortical activity in this particular area by targeting it through either TMS or TDCS, then probably you can bring therapeutic changes. So cathodal TDCS over this site is found to be effective in reducing the hyperactivity of this area, which can have potential role in management of bipolar affective disorder. A systematic review that included 19 studies, including 170 patients, they use TDCS in the management of bipolar affective disorder. Out of these 19 studies, 10 studies, they report that TDCS is effective in reducing the depressive symptoms. 4 studies, they reported that there is a beneficial role of TDCS in improving the neurocognitive deficits, improving the neurocognitive performance in patients with bipolar disorder who were even euthymic. They are recently achieved remission. Out of these 19 studies, there is one case report. This demonstrated the beneficial effect of TDCS on the manic symptoms. The rest 4 studies, they were quite inconclusive about the role of TDCS in the management of bipolar affective disorder. The transcranial random noise stimulation is a newer form of it's a form of transcranial direct current stimulation only. Here the electrical current is not going in a static manner. It is going in a arbitrarily fluctuating manner. So we call it a electrical noise. So transcranial random noise stimulation is used in the treatment of depression, both unipolar depression and bipolar depression. Anode is placed over the left dorsolateral prefrontal cortex and cathode is placed over right dorsolateral prefrontal cortex. Patients, they received 20 sessions of RNS over a period of 4 weeks, daily 1 session. There is no significant difference in the response rate and remission rate, those who are receiving active and those who are receiving SAM TRNS. So it indicates that TDCS is effective, but if you are planning for TRNS, it may not be so effective. So probably require more number of studies to establish whether TRNS is having a beneficial effect in management of bipolar affective disorder. Vagus nerve stimulation has been attempted in patients with bipolar affective disorder management. The researchers, they use vagus nerve stimulation in the management of bipolar depression. Improvement in the depressive symptoms in both unipolar and bipolar depression, they are not significantly different. So vagus nerve stimulation causes improvement of the depressive symptoms both in unipolar depression as well as in bipolar depression, and the response rate is quite similar. I will tell that the patients who are included in vagus nerve stimulation studies, they are mostly limited by small samples. A study that conducted over 9 patients with rapid cycling bipolar affective disorder over a period of 1 year. These are the treatment severe depressive episode patients, and most of the patients are having treatment refractoriness. After vagus nerve stimulation, the response rate, these difficult to treat patients, they have 38% reduction of the severity of the depressive symptoms over a course of treatment of 1 year. Treatment-resistant bipolar patients has been tried with vagus nerve treatment, and significant reduction of depressive symptoms and suicidality has been noted over a period of time. So when one need to consider about vagus nerve stimulation, one need to confirm the primary diagnosis of major depressive disorder, may it be unipolar depression or bipolar depression. The current mood episode should be a longer episode, or there should be more than 3 previous episodes. And to consider vagus nerve stimulation, either the patient should have received a trial of electroconvulsive therapy, but at the end of electroconvulsive therapy, the patient relapsed, requiring maintenance electroconvulsive therapy. If electroconvulsive trial was not given, then probably the patient must have received at least more than equal to 2 trials of psychological interventions, out of which one should be in combination with pharmacotherapy, or there should be at least more than equal to 4 antidepressant failed trials, or there should be at least more than equal to 2 augmentation strategies adopted, like augmentation of antidepressant with either mood stabilizer like lithium, or antipsychotic like quetiapine, aripiprazole, or risperidone, or the patient has received 8 sessions of PCT. then you may think of, despite of all these strategies, patient had longer hospitalization, repeated hospitalization for more than 6 months. So these are the group of patients who are adequately treated with multiple modalities of treatment, refractory to treatment, difficult to treat. Then probably these are the indications of vagus nerve stimulation. You need to exercise cautions when considering vagus nerve stimulation. Rule out personality disorder. Look for whether there is an active substance use. Rule out comorbidities like psychosis, compromised mental capacity. All these things need to be addressed before going for vagus nerve stimulation. Magnetic seizure therapy has been tried in patients with bipolar affective disorder. It's another neuromodulation technique where magnetic stimulation is given in very high frequencies that produces seizure, and it is considered as an alternative to electroconvulsive therapy. Open label study in patients with bipolar depression using magnetic seizure therapy. The remission rate is somewhere around 30% and response rate is somewhere around 50% who completed the treatment protocol. Again, I will say that though these refractory bipolar depression patients respond well to magnetic seizure therapy, again, these effects are mostly acute. People tried it with adolescents with depressive symptoms, adolescents with bipolar depression. People tried it with elderly population too, tried it with unipolar and bipolar depression too. So systematic review that included 8 studies, including both unipolar and bipolar depression, they found that the response rate is ranging between 30 to 40%, and it is mostly well tolerated and having a better cognitive functioning in comparison to electroconvulsive therapy. Those who are receiving electroconvulsive therapy, they have more cognitive side effect. Those who are receiving magnetic seizure therapy, they have lesser cognitive side effect. Though there is no head-to-head trial comparing the therapeutic efficacy and cognitive benefit between magnetic seizure therapy and electroconvulsive therapy in patients with bipolar affective disorder. Again, these studies, they have a limitation of a small number of bipolar depression patients are included in these studies. In a recent study, magnetic seizure therapy was used as a maintenance treatment of treatment-resistant unipolar and bipolar depression. But 12 booster sessions are given over a period of 6 months. So every 2 weekly, one session of magnetic seizure therapy is given after delivering a session of acute treatment of mood episode with magnetic seizure therapy. It is found that nearly 2/3 of the patients, they reported significant improvement of their depressive symptoms. So whatever neuromodulation technique you consider, probably you need to consider about maintenance sessions because most of the benefits are acute benefits. Invasive technique like deep brain stimulation has been attempted in patients with bipolar affective disorder. Significant improvement is reported in the depressive symptoms. Obviously, there is a risk of switch to mania or hypomania is there, but the risk of switch to hypomania or mania is a rare phenomenon. Some important cortical areas, deep cortical areas has been identified like bilateral subcallosal cingulate cortex, superolateral branch of the median forebrain bundle. They are identified as the important target areas for deep brain stimulation, the management of depressive episode. So DBS has been attempted in patients with unipolar depression and bipolar depression. The efficacy is almost similar. This is what the preliminary evidences say. Safety efficacy of DBS has been tried on the new target, that is central antral limb of the internal capsule. This is the common target that is recommended for the management of OCD. Even patients with Parkinson's disease, even patients with essential tremors, this VALIC is the target area. So 5 patients with OCD with comorbid bipolar depression. This is a very difficult to treat condition when OCD and bipolar affective disorder are comorbid together. After DVS, it is found that there is significant reduction of the OCD symptoms as well as depressive symptoms. In this study, they found that the risk of switch to hypomania and mania are very high. So it is a transient phenomenon. I will say that individuals with OCD, they usually need a relatively higher dose of anti-obsessive medication like serotonergic medications. Probably that increases the risk of switch to mania if it is in the context of a bipolar affective disorder. So that might be the reason why there is a relatively higher risk of switching to hypomania or mania. So it is a transient phenomenon. So there are some final concluding slides to summarize. Magnetic seizure therapy, transcranial alternative current stimulation, transcranial random noise stimulation, auricular stimulation, trigeminal nerve stimulation. These are some important neuromodulation technique that has been tried in the human population. Optogenetics, thermal, chemical, sonic stimulation are mostly in the animal studies. We are yet to have some large robust evidence regarding its use in management of bipolar affective disorder. Among the neuromodulation technique, magnetic seizure therapy, transcranial auricular stimulation, trigeminal nerve stimulation, random noise stimulation, they are found to have some role in benefiting the depressive mood episodes. So probably these are the future areas. Subsequent further intensive research is required in a larger population to see whether transcranial random noise stimulation, auricular stimulation, or trigeminal nerve stimulation is useful in bipolar affective disorder management or not. This is an interesting article published in British Medical Journal 2019. This compared the efficacy and acceptability of non-surgical, that is non-invasive brain stimulation technique for the acute treatment of major depressive episode in adults. That included both unipolar depressive episodes as well as bipolar depression, patients with bipolar depression. They did a systematic review and network meta-analysis. The interesting findings are, you see that risk of bias is high in only 17% studies. There is low risk of bias in nearly 1/3 of the studies. So bias studies are very less. They found that the response rate is, if you are treating a affective episode, depressive episode, may it be unipolar depression or bipolar depression, and you are using a neuromodulation technique, then probably you will get a higher response rate if you are using electroconvulsive therapy. Preferably over bitemporal electroconvulsive therapy than bifrontal electroconvulsive therapy. Even RTMS is also having a beneficial role in terms of response rate is considered. Priming, if you are doing a priming, before priming is usually researchers, they do priming by giving 6 Hz. It's a high frequency RTMS, 6 Hz frequency, 600 pulses per session. So you do a priming by high frequency RTMS, then you give low frequency RTMS. Once you prime the cortex, then by high frequency RTMS, then give low frequency RTMS, then probably when you give priming, it causes stimulation of the glutamatergic neurons. So it potentiates the effect of GABAergic activity that is induced by the subsequent low frequency RTMS. So priming facilitates the low frequency RTMS efficacy. So recently researchers, they are using priming technique before giving low frequency RTMS. So if you are doing priming or giving bilateral RTMS, or you are giving low frequency RTMS on the right side or high frequency RTMS on the left side, that is beneficial for the therapeutic effect. That is having a high response rate. If you are using theta burst stimulation, then probably bilateral theta burst stimulation or intermittent theta burst stimulation is more effective in terms of therapeutic response. Other evidences suggest that ADCS and magnetic seizure therapy may be effective, having a relatively high response, but the highest level of response is with electroconvulsive therapy followed by RTMS, particularly low frequency RTMS over right dorsolateral prefrontal cortex or high frequency RTMS over left dorsolateral prefrontal cortex. So this forest plot of this interesting meta-analysis suggests that response rate is highest with bitemporal electroconvulsive therapy and response rate is lowest with continuous theta bar stimulation. When we talk about cause discontinuation rate, particularly when you are giving low frequency RTMS, that is having a less discontinuation rate. When you are giving bilateral theta bar stimulation, that is having a relatively higher discontinuation rate. So here I will summarize that neuromodulation technique ranging from electroconvulsive therapy, transcranial direct current stimulation, transcranial magnetic stimulation, deep brain stimulation, vagus nerve stimulation has been studied in patients with bipolar affective disorder. Most of the studies, the target population is bipolar depression. Very few studies are there, mostly in the manic patients. Whatever the studies are there in the manic patients, mostly the studies are done by using the electroconvulsive therapy. So whatever existing evidences exist till date that suggest that electroconvulsive therapy is probably the most effective modality of neuromodulation in management of bipolar affective disorder, may it be a depressive episode, may it be a manic episode. In terms of durability of the therapeutic effect, mostly the neuromodulation technique, they give acute benefit, acute control of the symptoms, and mostly the symptoms usually relapse after discontinuation of the neuromodulation technique. Probably the individuals require maintenance neuromodulation technique for the relapse of, for prevention of relapse of further mood episodes. We need to have more number of studies, particularly in a larger population, particularly comparing head-to-head different neuromodulation techniques to see whether which neuromodulation technique is more superior and more efficacious and more acceptable in the management of bipolar affective disorder. Thank you so much.
Okay, thanks to you so much. I think Daria, I think you're starting now, but can we just give some time for questions? I don't know. So I had quite a few questions, even though I have no big experience in ECT or TMS. So what does it, what I never really understand is what is really happening in the brain or in the nerve cells in neuromodulation? So what is modulated? Usually, do you have a higher activity of the specific cells? And the question is, you have a very, very large area. So how do you focus on specific areas when you don't even know precisely what's happening in mania or depression? So that's about modulation. So what's happening in the brain and how to focus. The other thing is, many places possibly don't have all these different types. So does it make sense to do TMS after ECT, or would you do TMS first before ECT? And what does it mean, that the interleukin-6 increases? So these are a few questions from someone who has no big experience in that.
Okay, so let me respond to your first question. Neuromodulation techniques, they cause specific changes in the brain. When we talk about techniques like electroconvulsive therapy or magnetic stimulation, magnetic scissor therapy, they causes diffuse brain stimulation. All the areas of all the neurons of the brain, they are modulated. Various changes happen in the brain in terms of inflammatory changes, increase in level of BDNF, increase in neuroplasticity, cortisol suppression, synchronicity of neurotransmitters between the hemispheres. All these changes happen because of electroconvulsive therapy and magnetic scissor therapy. But when you talk about the newer neuromodulation technique like transcranial magnetic stimulation, when you talk about transcranial direct current stimulation, these techniques basically target specific brain areas. When you are treating a depressive episode, some neuroimaging studies, they suggest that in a typical patient with depressive episode, there is metabolic inactivity in the left dorsolateral prefrontal cortex. So when there is metabolic inactivity, there is decreased uptake of glucose in the left dorsolateral prefrontal cortex. There is decreased cerebral blood flow left dorsolateral prefrontal cortex. All these specific changes happen in a depressive episode. So if you target the left dorsolateral prefrontal cortex, by stimulating the left dorsolateral prefrontal cortex, probably you can enhance the metabolic activity, you can improve the glucose uptake, you can increase the cerebral blood flow. That helps in improving the depressive symptoms. So when a depressive episode happens, when all these types of metabolic inactivation happens in the left dorsolateral prefrontal cortex, so right dorsolateral prefrontal cortex overtakes the role of left dorsolateral prefrontal cortex. So as a compensatory phenomenon, there is hyperactivity of right dorsolateral prefrontal cortex. So probably that hyperactivity of right dorsolateral prefrontal cortex interferes with the recovery from depressive episode. So you need to inhibit the activity of right dorsolateral prefrontal cortex, and you need to stimulate the left dorsolateral prefrontal cortex. So that's how the specific neuromodulation for the depressive episodes they target. When you are using RTMS, either you can stimulate the left dorsolateral prefrontal cortex or you can inhibit the right dorsolateral prefrontal cortex. But if you are using TDCS, you have that liberty to use two electrodes simultaneously. You have a cathode, you have an anode. The cathode placement causes underlying cortical inhibition, anode placement causes underlying cortical stimulation. So now simultaneously you can stimulate the left dorsolateral prefrontal cortex by placing the anode there, and you can inhibit the right dorsolateral prefrontal cortical activity by placing the cathode there. So this is specific neuromodulation that is happening by using PDCS. When you go for vagus nerve stimulation, again the target areas becomes different. The vagus nerve is having the nerve root in the brainstem, and the nerve root of the vagus nerve nuclei, they have connections with locus coeruleus and specific brain areas that is important for mood regulation, particularly the noradrenergic containing neurons. They are located in those brain areas. When you stimulate the vagus nerve, that causes release of noradrenaline and mood elevation. When you are using deep brain stimulation, again you are targeting specific brain areas. May it be vallic, ventral, internal, ventral aspect of the internal limb of the internal capsule. That can be one target area, or it can be the forebrain bundle that can be targeted. So these are some important areas where you can focal neuromodulation. This is the response to your first question. If you want to clarify before giving neuromodulation, if there is a facility, then functional neuroimaging or PET scanning can be done, so that the individual will be able to know which area of the brain is having increased glucose uptake, increased metabolic inactivation, or hyperactivity of which brain area. That can be elicited through functional neuroimaging. Or researchers, they also tried with using EEG. Researchers, they also used functional near-infrared spectroscopy to look for the bold signals, blood oxygen derived signals. Which area of the brain is having more oxygenated blood, which area of the brain is having less oxygenated blood. Accordingly, you can decide which area of the brain is having inactivation, which area is having hyperactivity. Accordingly, you can plan for neuromodulation. This is response to your first question. Regarding the second question, you asked me about when to choose electroconvulsive therapy, when to choose transcranial magnetic stimulation. Suppose somebody has received a trial of electroconvulsive therapy, can we go for transcranial magnetic stimulation or TDCS? It's all about because all these techniques, they have a different mechanism of action. If you have facility of all these facilities, usually since they have a reluctance to go for electroconvulsive therapy. If you have facility for EMS or TDCS, of course, these techniques are more acceptable by public. In our center, we are having all these three facilities, but when we offer these techniques, usually patients, they go for TMS or TDCS before going for electroconvulsive therapy. Considering the fact that it is associated with more cognitive side effect, it is relatively, you need to be administered under the giving anesthesia and so many things. So you can try with transcranial magnetic stimulation or TDCS. Non-responders can be enrolled for electroconvulsive therapy subsequently.
Okay.
Regarding your third question, interleukin-6. Interleukin-6 is an inflammatory marker. Consistently found that patients with depressive episode, they have a higher level of inflammatory markers, oxidative stress markers, nitrous oxide markers. All these markers are raised because of hypothalamo-pituitary adrenal axis stimulation at a higher level of cortisol that facilitates the immunological or inflammatory changes in the body. So probably treating the depressive episode made by pharmacotherapy, made by neuromodulation, reduces the level of these inflammatory markers that is found in CSF as well as found in the plasma level.
Okay, I think I don't know if there's an urgent question. I would, I think we're a little bit over time. I think I will possibly have to invite you to give us an update next year again. Is there any other questions from anybody else? I just and if I can ask you to answer it in a short way, then anybody else having an important question? Okay, if I don't see anything, I think you just covered everything. And I think I learned a lot. I have to go through the slides again because, there's so many different types of stimulation. And here where we are, we have very little of that. And ECT has a very bad reputation. Okay. Okay, thanks a lot. And yeah, thanks for this very, very comprehensive talk. And I hope people will enjoy it on the YouTube. Thanks a lot. And now I would ask Daria to just share the slides, if that's possible. Just can you get that proper? Do you want to? Okay, that's fine.
So you see the first slide, yes?
Right. Okay. Can I just introduce you quickly? I think you're coming, Daria, is professor of psychiatry, and she's director of the International Center for Educational Research in Neuropsychiatry at Samara State Medical University in Samara, Russia. And yes, she has a very interesting title where we had to, which we discussed here before, what does it mean precisely? But I think it's a very, very challenging title. So schizophrenia, we need the right words to be found and the real actions to be done. I think at least I agree with the latter. Okay, thanks Daria for joining, and we are quite excited to hear you talk.
Many thanks for this introduction, dear Professor Reiner. And first of all, dear colleagues, I would like to express my gratitude for inviting me to join this important professional event, the second conference of the Global Psychiatric Association. And I hope I will shed some light on the words and actions which should be spoken and done related to schizophrenia and treatment of our patients suffering from schizophrenia spectrum disorders. Here I represent, as Professor Reiner kindly mentioned, the International Center for Education and Research in Neuropsychiatry, which has been organized in our university 2 years ago. And the information about some advertisement, the information about our center has been published in the World Psychiatric Association Review, and have been supported by the president of the World Psychiatric Association, Professor Afzal Javed, and the General Secretary, Professor Peter Morozov. And actually what was new from our country is that we have been first who employed foreign professors on remote contracts to our international team of the center. And this slide I would like to show in the memory of our dear Professor Peter Morozov, who is my mentor, my tutor over the last more than 10 years. And he was really and is really still the source of inspiration for many of us, and he will remain in our hearts forever. Really, I didn't listen to him sometimes, and I did on my own sometimes as his student. But what I would like to say that now I try to ask him for advice in my heart and in my mind, because he was always right. And I like this picture very much, with which our dear colleague, Associate Professor Maya Kuligina, sent me. This picture was made on the cruise ship of the Volga River in Russia. And Professor Peter Morozov was always wise to know which way to go. And we hope that we will go the right way in the next years and in the future and tomorrow. So this is our international and interdisciplinary team, and we are really glad and proud that we have people with different who work with different specialties, disciplines, and we would like to build up really a dream team with good communication, with good collaboration, with understanding each other. So we have psychiatrists, psychotherapists, and specialists in neurology and clinical psychology, laboratory diagnostics and genetics and pharmacogenetics, immunology, neuroendocrinology, neurobiology, and also we have people who work very good way in statistics and research design and pharmacology and even IT, information technologies, which help us to build research projects in this interdisciplinary paradigm. And it's very important because my talk is also devoted to this interdisciplinary approach in psychiatry, when psychiatry meets linguistics. And this is our key project. We follow now this innovative neuropsychiatry research bank, and we have different project initiatives, including creating digital research protocols, and also we use transcranial magnetic stimulation. And thank you very much for this outstanding lecture delivered by Sujit. And I think we would be happy if Sujit would agree to collaborate with us on our first steps in transcranial magnetic stimulation regarding bipolar disorder and in particular bipolar depression, because my question to Sujit was who are those 7.7% responders among bipolar depression patients who respond. So we now work on dynamics and of inflammatory markers as well, and pharmacogenetic issues and markers as well. And we study endophenotypes of bipolar disorder and schizophrenia spectrum disorders, those who are responders to different sorts of and kinds of treatment. And research I'm going to talk today and to put the key message today is related to the initiative of schizophrenia cognitive endophenotype, which we elaborated together with the University of Western Australia, and as well as language of mental disorders, because we study linguistic patterns of depression, dementia, and schizophrenia. Together with the Israeli, Australian, and Russian interdisciplinary team of linguists, psychologists, and psychiatrists. And it's a bit about our center. We have also collaboration with different associations. And yesterday, Professor Subodh kindly delivered his lecture about education. And we collaborate with Subodh, and we have official memorandum of understanding signed between our institutions. and with Russian institutions as well. But what is important, we are based now, finally, we are based at the Samara Regional Clinical Psychiatric Hospital, and we have more than 1,300 beds. So we have full access to our patients to study, research them. And we also have the project of ICERN Web Library of Neuropsychiatry, and maybe we would be happy to share the lectures of the Global Psychiatric Association at our web portal, and refer to your website and advertise your website as well as the journal. So this is the psychiatric hospital and recent opening ceremony. And we also collaborate with Professor Florence Thibault on women's mental health, but what we would be talking today about schizophrenia is mostly affect male population as well. And also with the WHO, we are the supporter of the Pan-European Mental Health Coalition, working on transforming, on the working packages, transforming mental health services and post-COVID consequences. So finally, after many words, I move to the key issue of my talk, and the key questions I'm going to follow to remind all of us what kind of the disorder schizophrenia really is. Why do we need to pay attention on the language impairment, a so-called thought, language and communication disorder, and words spoken by our patients with schizophrenia? And what does the decline in action-related language tell us about schizophrenia, and which actions should be particularly done to treat schizophrenia as a linguistic disorder, language disorder, as some groups of researchers consider to develop. So what is schizophrenia? When we're talking about schizophrenia, we're talking about schizophrenia spectrum disorders. And as Spence wrote, it's one of the most extreme states that human beings can inhabit. ICD-10, you can see this in the text, describes schizophrenia as a fundamental disturbance of personality involving its most basic functions, which give the normal person a feeling of individuality, uniqueness, and self-direction. That's a very interesting, how to say, sculpture monument, which is can be found in the corridor of a clinic in Munich, where Kraepelin worked. So this is how, this self-direction and this basic function can be disintegrated in schizophrenia, metaphorically. Schizophrenia is not a disease in the strict sense, but appears to be a group of diseases. And therefore, Bleuler said we should speak about schizophrenias in the plural. As my teacher, Professor Asen Jablensky, also prefer to emphasize, to specify, schizophrenia is not a nosological monolith, but rather an assembly of syndromes structured into relatively distinct subtypes of disorder. So when we're talking about schizophrenia, we're talking about subtypes and the phenotypes and heterogeneity of schizophrenia. The course of this disorder, a group of disorders, is not inevitably associated with deterioration. We know that around approximately 60% of patients had multiple episodes with complete or either partial remissions, while only 30% experience continuous disabling illness. And we all know this big study, epidemiological study, which has been supervised by WHO, and Professor Arsen Jablensky and Professor Norman Sartorius led this multi-center research. It discovered that more than half schizophrenia patients eventually attain a symptomatic and functional remission, and the duration of psychotic symptoms in the first 2 post-onset years is a predictor of symptoms and disability at 5-year and 15-year follow-up. However, the findings related to social support, daily living, and community functioning, that is what really causes serious concern. Around 80% of patients are unemployed. More than 60% report difficulty in socializing outside their homes, and 30% living alone. Also, this feeling of loneliness, which is related and proved to be related to cognitive dysfunction and social isolation, experienced by many of patients. Yes, indeed, 30% live alone, but half and more than half of schizophrenia patients experience the subjective feeling of loneliness, disruption in communication. And if you remember Henry A., who defines schizophrenia as a chronic psychosis characterized by a process of mental breakdown, that can be called dementia praecox, intrapsychic discordance, or autistic dissociation of personality. Schizophrenia is characterized by the manifestation of a deep tendency to stop constructing one's own world in communication with the other, to disrupt the communication, to get lost in autistic thought. And maybe this is the target we should focus on when we discuss this thought, language, and communication approach, treatment approach in schizophrenia as one of the key targets to socialize our patients and to improve their quality of lives. I also like this paper by Stephenson and Helen Stephenson and Joseph Parnas, who is famous for his papers in clinical psychopathology, when they describe the self-disorders in schizophrenia. And they describe subjective experience of patients who say that they're losing contact with themselves. And the self-disorders could be presented with the disruption in self-monitoring, and excessive self-monitoring, self-alienation, self-defragmentation, self-deprecation, self-doubling, and self-reflection. And I like this citation very much. It's the wordings, statements from patients, except from patients' speech. When I'm with others, there are 2 eyes. The eye who is among them, and the eye who objectively looks at this eye. No matter how much I'm absorbed in something, there is always an eye that looks on from the outside dispassionately. This latter outer self is always managing and controlling me. Even when I talk with others, the outer self listens to their words and tells them to the inner self. After listening to this, the inner self starts to talk. The inner self speaks what the outer self commands it to do. And in this citation and these statements, we can recognize the symptoms of thought disorder, the symptoms of auditory verbal hallucinations, and other symptoms which are related to thought, language, and communication disorder in schizophrenia. So the patients suffer from this inner alternation, which is almost impossible to verbalize clearly. But the key point is, as we can see, that they're losing communication with others and losing contact inside their own. And also, very interesting paper published by Boricius about subjective experience of the patients we should pay attention to. negative symptoms, K symptoms, as Bleuler and other psychopathologists emphasized, which are the K symptoms of schizophrenia, the basic symptoms, while psychotic symptoms are just secondary to these negative symptoms. Core symptoms of schizophrenia. Well, we can see this in even in patients' verbalizations. So, we are talking about a lack of insight, but we can find these difficulties which our patients experience in what they say. So this what I emphasize here, the slide, the stuck in my thinking, brain paralyzed between fear and love, stuck on you, stuck between the last word and the next. So blocking, the symptom of thought blocking. Stuck by confusion, the inability to proceed any further in understanding of speech. So again, thought and language. Well, I'm just stuck again. It's very interesting, really, to find this evidence in patients' verbalizations, which give us the key, what we should focus on in our treatments. And the key point message, and the paradigm we follow is guided by psycholinguistic approach, which we develop in our department, and maybe just because we had just paper and pen, and now we have, of course, transcranial magnetic stimulation and reagents for measuring genetic markers. But previously, it gave us opportunity to study patient speech and to think more about linguistics. The paradigm we follow is guided by psycholinguistic approach. As I say, it's equally important to pay attention and listen to what patient speaks about and to how it's spoken. And there were different studies we managed. I told you that we managed to study on depression, when we found that patients with depression use, for example, verbs in past tense more often compared to future and tenses and present tense, and use more personal pronouns, focusing on their state. But what is related to schizophrenia, our project in collaboration with Israeli colleagues, you can see here, Jonathan Fine, unfortunately passed away, and Professor Joel Walters, professors of the Department of English of Bar-Ilan University, and here you can see Professor Haim Robert Belmaker from Ben-Gurion University of the Negev, and Professor Yulia Bersutsky and Professor Vladimir Lerner, who are bilingual in maybe trilingual, multilingual in Hebrew, Russian, and English, of course, is international language. And we have been working on the text of Russian immigrants to Israel. And it was very interesting because there were some findings in the clinical team, and there were some findings based on linguistic analysis, but both groups couldn't find what it really meant, those findings. And then we had brainstorming and realized that the second language really could act as a compensatory resource to maintain verbal fluency in schizophrenia. And it's very important because studying second language, foreign language, could be a resource for remission in schizophrenia. We dared to say in our research hypothesis. And we also know from published papers and recent papers that it's the same in Alzheimer's disease, that people who are multilingual or at least bilingual, they have the onset of Alzheimer's disease, dementia, later in 4.2 years. And we published our paper about this verbal fluency effect. And also we published a chapter which is available online now, and the ResearchGate, and we described there how schizophrenia is represented in bilingual brain in both languages, and also how bilingualism can affect the course of schizophrenia and be revealed through the symptoms of schizophrenia. And everything is done through the conversations, through the via communication between psychiatrists and linguists. And I just remind you about neurobiology of language, and of course everyone knows from students' years about Broca's area and Wernicke's area, and of course it's much more complicated what's going on in the brain, not just these language areas, which have been described as Broca's areas, which helps in producing coherent speech, and we have incoherent speech in schizophrenia, and Wernicke's area, which helps in speech processing and understanding language, and our patients fail in pragmatics and semantics, and they have failure in understanding the real meaning of the message in social communication. So Ellen Chaika, if you read this very impressive paper, she was a linguist who described the case of a schizophrenia patient. She said that language disturbances in schizophrenia remind some sort of intermittent aphasia. And of course, there are many things we can say about neurobiology of language, and many areas to mention, and there are different models and networks which are responsible for spoken and written language, and it's different in monolingual and bilingual and multilingual brain. And if a person's suffering from schizophrenia, it's much more difficult to explore and to understand what's going on. But what is important, maybe really, we can see some vulnerability of fragile left hemisphere, left brain in right-handed persons. And if we see this brain from the bird's eye view, the language, speech, areas, related areas, thinking and understanding the context, as well as social communication and ability to learn behavioral patterns, mostly related to the left hemisphere and right-handed persons. So the basics of neurobiology of language is that grammar and syntax, so how we build sentences, statements, and use words, are based on Broca's area, and acquisition of phonosemantic component on Wernicke's area, while lexical and semantic processing is associated with activation in temporal and temporoparietal regions, including the medial temporal lobe. Retrieval of lexical and semantic data leads to activation in anterior prefrontal cortex, so that according to the declarative procedural model, the mental lexicon depends on declarative memory with the temporal lobe, whereas the mental grammar involves procedural memory and is rooted in the frontal cortex and basal ganglia, which we know is impaired in schizophrenia according to neurobiological findings, so postmortem findings. And we know the symptom of difficulties in lexical access, which our patients express subjectively, and we find it in an objective way. And it's also related to what we state here. Verbal fluency is normally associated with the left inferior frontal gyrus. And some difference in bilingual and monolingual brain, which I would like to emphasize, that weak second language is processed through brain mechanisms that differ from those underlying first language, native language processing. And Broca's area is the language organ only for native languages. And when a person speaks 2 or more languages, everything is already different in the brain. And it depends on the level of language acquisition and the age where the language has been learned, acquired by a person. And it depends how neural networks are interrelated and how hemispheres are interconnected, related to language processing and language understanding. And also very important to pay attention on anterior parts of the left prefrontal cortex and the anterior cingulate cortex, which are involved in second language processing. What is also interesting that the brain impairment in schizophrenia is represented in frontal cortex and other areas in left hemisphere as well. At least it have been emphasized in the series of studies, but the researchers discuss, of course, neurobiological evidence on specific deficit in left hemisphere for schizophrenia have been, and left dorsolateral prefrontal cortex have been mentioned in many studies. And the brain impairment in schizophrenia, yes, we should focus and we should focus our attention on the failure of hemispheric dominance for language consent. Which describe decreased cerebral lateralization, structural and functional asymmetry, and the distorted interhemispheric connectivity, and other phenomena which can be corrected when a patient or when a person speaks several languages, for example, or is involved in so-called action language therapy, action language treatment, language exercises, not only cognitive rehabilitation, not only cognitive behavioral therapy, not only cognitive remediation, but also particular language remediation therapy. That's what we are thinking about, this particular approach to be able to treat schizophrenia patients. Dorsolateral prefrontal cortex dysfunction is one of the key paradigms related to cognitive disruption in schizophrenia. And this is our paper, which has been published with the team guided by Professor Asun Jablensky and the Oxford graduate Professor Joanna Badcock, really experienced psychiatrists and clinical psychologists. We studied fluency deficits in schizophrenia spectrum disorders on the basis of Western Australia family study of schizophrenia data set. So we should think about subtyping and the phenotypes of schizophrenia, because schizophrenia is characterized by variability of clinical phenotypes and extensive genetic heterogeneity, as we already said. And despite the hundreds of years of research described first by Blöhler and Krepelin, the multifactorial causes and biological underpinnings of schizophrenia and related disorders still poorly understood, and maybe the language could be the real key to understand it, and thought, communication, and language and internal speech could be the key to understand etiopathogenesis, etiopathogenetic mechanisms of schizophrenia. And this is the endophenotype research, which is followed by several groups, and one of the group in the University of Georgia, supervised by Brad Clements, and this study has been funded by National Institute of Mental Health in the United States, which lead to the notion that multiple biological pathways can lead to similar symptoms, and we need to study biological underpinnings and those biotypes which can predict the disorder course and outcome. So which patients respond to psychotherapy, which patients, which cohort category of patients respond to transcranial magnetic stimulation and this sort of kind of matters, and which patients should respond to dopaminergic drugs. So it would be efficient to know in advance who is responded to any sort of treatment, and we dream about finding markers, biomarkers, including language markers, how to subdivide these patients' cohorts and to treat them right from the beginning, not to allow the course of the schizophrenia to be bad, to lead them to devastating consequences. And one of the groups of endophenotype research is based in Western Australia, supervised by Professor Asen Jablensky, and I was lucky to win this fellowship and to work for 3, even more years, if we include remote work as well, under the guidance of dear Professor Asen Jablensky, the former director of the Center for Clinical Research in Neuropsychiatry. He moved from Bulgaria to Perth, Western Australia, and got funded for this extensive research. They have everything, blood samples bank, the wide variety of psychometric measures, investigation of family members, and everything stored over 25 years. So it was amazing, and we had access to linguistic data to study, for example, action fluency testing, this big cohort of patients. And really following this direction is what we are now doing in Russia. We have this bank of research when we collect different data from our patients, including biosamples and linguistic data in Russian-speaking patients to compare languages as well. Cognitive endophenotypes, it's very important. That was, and I just remember you this concept of endophenotypes which are associated with illness, but not part of the diagnosis per se. They have hereditary nature, and we can find the disturbances of language as well, thought, language and communication disturbances in families, in relatives of schizophrenia patients, and it expressed through any language you talk. So no matter where you live, no matter which language you speak, we can find these disturbances, this decline in language and thought and communication of our patients suffering from schizophrenia spectrum disorders. And what really it was the study based on Western Australia family study schizophrenia database. They found this at least 2 pure types, cognitive deficient and cognitively spared, and they especially been different on language and verbal related psychometric measures. And still the diagnosis remains primarily based on symptoms, self-reported subjective experience, like everything in psychiatry. And yesterday, Professor Norman Sartorius told us that when we speak about this phenomenon of horizontalization and we speak about the layers, social layers, it was the difference in diagnosing schizophrenia proportionally to this level of difference between doctor and patients belonging to different social layers. And so the language and speech are the primary source of data for psychiatry, both to diagnose and to treat mental disorders. So if patients are mixed up with language, so we need to help to go back to healthy language. We hope so. So if epigenetic works, maybe we can affect again through external factors to treat the disorders, in particular schizophrenia. And Wolfram Hinzen is one of the famous linguists who was originally from Spain, but worked in England, in UK. He had several grants supported the linguistic hypothesis of schizophrenia, and he emphasized that all these positive symptoms, including auditory verbal hallucinations, formal thought disorder, and delusion, are also lie in the language-mediated underlie language-related neural circuits. And in a historical point of view, we remember Kraepelin and his descriptions of language phenomena, and also Carl Kleist. I would like to remind you of thought disorder and dysphasia and schizophrenia, and Cameron, who mentioned acidentic thinking and over-inclusiveness, and were the approximations, metonymic distortions in patients' language. And Ellen Check, I already mentioned, who said that language disturbances are some sort of intermittent aphasia. And what is important that almost all language levels are impaired, are disturbed in schizophrenia. So speech comprehension, semantics, fluency, complexity, reference failures, grammar, language lateralization. So this is the summary of the main linguistic findings described in the literature. And Nancy Andreasen, clinical psychologist and professor in the University of Iowa, she was the first one who introduced the language criteria of schizophrenia to DSM classification, DSM-3. And then we found this in DSM-4, migrating to DSM-5 as the frequent derailment or incoherence of speech. Also ICD-10, you can see on the slide, and then ICD-11, we still have this paucity of speech. And there are different tools which could be used to screen language disturbances in schizophrenia in different domains, including impoverishment, disorganization and dysregulation of language, and Klang scale introduced by Chen with 17 symptoms put into 3 main dimensions and domain. And this paper I love as well very much, which was written by Timothy Crow, and this paper in 100 words about psychosis, which is the prize that Homo sapiens pays for language. So when we start speaking, the social reality and mind was duplicated because we have both material world and the world which was named with words. So we're mixed up with language and meanings. And that was what's happening, thinking in the evolution. And actually schizophrenia appeared as a mental disorder in the population. What is already proved across many studies, linguistics, clinical studies, neurobiological studies, that language abnormalities in schizophrenia are genetically determined, and we can find this thought, language, and communication abnormalities in relatives, but not reaching the symptom level. And it was published on the automated and Menon language analysis that using artificial intelligence and automatic machine learning, a speech classifier can really comprise semantic coherence and reduce usage of possessive pronouns, for example, as linguistic patterns, and with 83% accuracy can predict psychosis onset, because these subtle disturbances in language already evident in schizophrenia even prior to first psychosis onset and during prodromal stages of the disorder. So maybe even this screening tool which tests the language could also help us to identify groups at risk as well. And I hope I have 5-6 minutes more because we started a bit later. I'll try to be fast. So language in schizophrenia, the leading impairments still lie in the area of semantics and pragmatics, and if we turn to the normal aspects of conversational speech, so it's characterized by spontaneity. Utterances, statements occur spontaneously, not only as a response to questions. This language speech is fluent, non-fluent speech is halting and laborious, often with poor articulation. So normal language, normal speech is tone-taken. It shares mutual topic. It is characterized by comprehension. So each participant understands the utterances of the other, and it makes sense. So it's not like formal thought disorder, and it's associated behaviors of facial expressions, gestures, body language, which convey conversational information, and which is disrupted in schizophrenia. And what we focused on in our study was the fluency test, because we found that the poor fluency and deficit in fluency have been recorded in many studies. And by the way, recently we published a review on TMS efficiency, and we found those who were responders, they have dynamic in language tests. That also could be maybe one of the answers for the question, who those patients who respond to this or that treatment in psychiatry, neuromodulation, neurostimulation, and etc. And so we focused on fluency of our patients, and we elaborated we studied the information about deficits in action planning, which our patients with schizophrenia experience, and we focused on this research which proved that schizophrenia patient experienced damaged action fluency, in particular, not only phonological and semantic fluency, but action fluency and poor verbal fluency, which was related to the reduction in semantic memory store. So problems with managing meanings. And we studied this decline in verbal fluency, which is a characteristic finding in schizophrenia involving a combination of mechanisms, including semantic processing skills, difficulties using contexts, so pragmatics, and executive dysfunction. And a semantic fluency deficit has already been previously proposed as potential endophenotypic marker in schizophrenia. But the majority of previous studies have focused on object words, nouns, in the semantic fluency task rather than action words, verbs. So we studied action fluency deficit in a previous study supervised by Joanna and Dasan. They proved that it was related to the symptoms, clinical symptoms of odd speech and constricted affect, which is important for communication and increased social anxiety, but not to hallucinations or delusions. So it's some specific construct. And we use this action fluency task, which is very easy, just 1 minute, 60 seconds. You need to ask patient to say as many verbs as possible, as many words that describe actions. And it's important that verbs, that patients with frontal lobe injury, for example, demonstrated verb retrieval difficulties, but retrieve nouns at normal levels. So it's different in the brain when you retrieve verbs versus nouns. So different areas are damaged. And we will find that action fluency is declined, verbs decline. It's related to specific region and specific functions. We can target in our treatment strategies across our treatment strategies. And the meaning of action words and actual movements activate motor and premotor cortex. And this rules out as specific unified meaning center. And you can see across different studies, there's face-related words, arm-related words, and leg-related words, as well as pronouncing verbs related to these actions, to the appropriate actions, activate the same, almost the same areas in the brain, movements and action words. So we move inside this topic scientifically deep, actually, and we also put into the focus the hypothesis that there is some cortical connections related to action words recognition and comprehension, and there are specific semantic connector hubs which are related to category specificity. And it was an interesting paper published in Nature, Semantic Atlas of Cerebral Cortex, which suggested that topographical differences in brain activation are driven by word meaning, action versus object semantics, rather than grammatical class per se, so not just verbs versus nouns, but the meaning of the verbs. So it's possible that some particular verbs are damaged, impaired in schizophrenia spectrum disorders. So we studied abstract versus concrete constructs and high motion versus low motion verbs. And what we really did, we classify all the verbs we had from this action fluency task from Western Australian Family Studies Schizophrenia. And we studied different characteristics, lexical characteristics like word length, word frequency, and valence. You can't imagine, but there are corpora of data which have been elaborated in Oxford and Cambridge, and which has all this data on every English word and verb in particular. And so all these aspects, all these parameters can influence words, verbs, retrieval, and comprehension. And what we found when we analyzed our data, comparing the study group and the healthy control group, using this action fluency task. You can see here the example of action fluency, schizophrenia and action fluency in healthy control. You can see the deficit, definitely. And we use the classification, English verb classes and alternation developed by Beth Levine, the Stanford classification of verbs. It has 48 classes, but we grouped them into two superordinate semantic categories: action verbs and mental state verbs. Verbs which refer to concrete observable actions, which are strongly related to specific body parts or regions, and mental state verbs, which are defined as verbs whose meaning related to understanding, discovering, planning, or deciding, such as know, feel, and believe, for example. And what we found that in patients with schizophrenia, action verbs suffered more than significantly more than mental state verbs. There is significant difference between schizophrenia spectrum disorders and healthy control related to action verbs production. And also when we specified this cognitive deficient phenotype and cognitively spared subject, it was also a trend and a significant difference. So what we found within the whole sample compared to mental state was that the action verbs generated were characterized by a shorter word length, lower word frequency, and earlier age of acquisition, and higher concreteness ratings, but didn't differ in valence in lexical characteristics. What is important, that action verb fluency deficit was correlated with the interpersonal domain on schizotypal personality questionnaire. Domains such as social anxiety, no close friends, and constricted affect, and with immediate and delayed recall scores on the verbal learning test. And I will just summarize the findings. The aim of our study was to investigate the specific features or region of action verb fluency impairments in schizophrenia. And we analyzed the verbs output in schizophrenia patients compared to healthy control using this specific cognitive linguistic approach, interdisciplinary approach. And we studied semantic categories, action versus mental state verbs, and their lexical characteristics, which really affect the production of every type of verb, and correlations of these parameters with cognitive and clinical features. And what we found that the proportion of action verbs suffered in schizophrenia compared to healthy controls and compared to mental state verbs generation. And it was not due to an effect of medication, because we studied correlation with clozapine, those components. It was unrelated to the fluency. It was not due to poor reliability of semantic categorization, because we have iterated reliability with several linguistic groups, anonymous analysis of all these data sent. And it was not due to lower intelligence or education of our schizophrenia patients, as we also proved, and not due to verb difficulty effect, because mental state are more difficult than action verbs, and they are acquired later in age than action verbs, but they didn't suffer in schizophrenia. Action verbs suffered, and not due to age-related decline, as I said. So we found this specific action verbs related deficit. And we found this greater difficulty integrating verbal and perceptual semantic representations associated with the concrete meaning of action verbs in schizophrenia patients, which because of this precision of encoding or reactivating perceptual memory codes. So it's related to memory and meanings in the memory. And what we would like to say and develop further is the study about, we're interested whether the degree of sensory motor impairment could predict the action verb fluency deficit in schizophrenia patient in line with the classical theories of embodied cognition. And this action fluency test can already show us the language pattern both in patients and relatives, as we now see in our cohort of Russian speaking patients. And what was the finding? I would like to say once again and emphasize that it was indicator of poor interpersonal functioning. And we found the increased sense of psychological distance from others related to this action verb fluency deficit proved revealed in our patients, observed in our patients. And this points to specific relationships between action-related language, memory deficit, and poor interpersonal functioning in schizophrenia spectrum disorders. And what we would like to implement the intensive language action therapy is as one of the part of cognitive remediation or separate linguistic language remediation treatment, when a patient can use action verbs and in the specific linguistic exercises, and when can patient move and communicate with reality. So this what Henry A. Said about schizophrenia: stop communication with others, stop communication with reality. We need to learn, we need to teach our patients how to interact with reality, also via learning verbs and training verbs production. So the message is to spread the word about linguistic paradigm related to mental disorders and to take an action to treat schizophrenia. Don't doubt, but do. Doubt is a mental state words, but do is mostly related to the action. So thank you very much. And for collaborative words and action, there is an email here, and we would be happy to collaborate. And maybe for the Global Psychiatry Archives, maybe we can dream about a special issue on a linguistic approach for mental disorders. I'm very sorry for being late and for too many words. I hope I will act more in future.
Thanks so much.
Thank you.
Thanks so much for this, and you're very much invited to organize a special issue on linguistic schizophrenia and certainly action, because I think that's the most important part. One of the things maybe, I don't know if there's other questions, I'd like to know where do these, very often, where do these, we call them neologisms come into this, So I think it's very